Thank you, Professor Renard, for coming
Good
to the
afternoon.
interview. We have known each other for many years,
Yeah.
and I'm thinking back, I don't remember, was it 1995 or 6
Yeah,
in Napa?
1985, I think. Yeah, yeah.
Yeah. And that was a society that no longer is in existence, the MT, or the, I'm sorry,
It's good.
the ISGID,
Yeah.
the International Study Group on Implantable Insulin Devices.
Yes, that's it.
So we met in Napa, California in 1995, and that was a international conference from all over the world to talk about this new device, the implantable insulin pump. And you were a young doctor, very new in your profession and starting your research career, and you chose to focus on implantable insulin pump and intraperitoneal insulin. Was that an easy decision for you, or was that?
Well, it was not so new in Montpellier because intraperitoneal insulin delivery was used among the first time in Montpellier. It was up to 1981. It was the beginning of the story of insulin pumps because there were very few that were even using sub-Q route. And at this time, my predecessor, my mentor, Professor Mirouz, disclosed that sub-Q route was not enough close to physiology. So the dynamics of insulin action when using the sub-Q route was not reproducing what was expected. It was not quick enough to prevent hyperglycemia after meals. And the big problem was also that after some time, there was too much insulin in the blood when it was no more needed. And so the patient had hypoglycemia. They were better with pump using CSIN than with multiple injections. But it was not the real way to mimic physiology. And so he, among others in Europe, decided that using the peritoneal route would be more physiologic because insulin will first go to the liver and the level of insulin in the peripheral blood would be close to the normal, which is not true when you use sub-Q. You have too much insulin when compared to normal. And so by this time, in the early 1980s, they implanted external catheter through the abdominal wall to allow insulin delivery using external pumps. And the results were quite astonishing because hypoglycemia was very rare. Some people who had brittle diabetes became easy to be controlled. And so it really changed the life of these persons. So, of course, the challenge was to make the system easier to use because with a transparietal catheter, an external pump, there were some issues of risk of infection around this catheter. And so, of course, the ideal way would be to have the pump implanted under the skin so that it would go to the peritoneum without this subcutaneous access. And the limit of this evolution was non-availability of insulin that could stay in an implantable device for a long time. And it became a reality when it was Hoechst at this time decided to create a new insulin that is still used, combining regular insulin with Genapol. Genapol is a solvent that prevents aggregation of insulin at body temperature. And from there, several companies like Infused, like Minimed, Siemens also in Europe, decided that it was a way that could really improve diabetes care. And of course, these people were all passionate. Professor Mirouz, Professor Selam, and Alman, who recently died. They really wanted to offer diabetic people treatment that would move them back to without diabetes, without having diabetes. And so finally, after some trials in US by Professor Sodek in Baltimore and also in California, they realized they built the first really implantable pump that could be used by many patients. It was the first model of MiniMed. The first one was implanted here in Montpellier on January 17th, 1990. And it was the first of a long series because by this time it was really viewed by the professional of diabetes and by the patients as a revolution, because they had no more needle, they came back to normal glucose control, few hypoglycemia, and so it expanded. And why did it stop, or why did it remain limited? The main reason was that this system, of course, was needed some further development after these initial pilot models that were validated, and it was mainly for industrial strategy decisions. Until MiniMed was taking care of these systems, they continuously improved. Initial pumps were available only for 3 years, and then they moved to almost 10 years, like now. Catheters were changed, were improved, very uncommonly blocked, which was not the initial story. Insulin stability was a bit variable, but it could be solvable. It could be, but when the MiniMed was bought by Medtronic, it became that the strategy of these implantable devices were not so good as, financially speaking, versus using a subcutaneous pump with subcutaneous sensors and so on. And so finally it survived up to now. We follow here in Montpellier about 100 patients, and in all the world there are about 450 patients, most of them in France, because in France we are following a bit more than 300 patients. And it is implantable pumps are only used in Europe, in the Netherlands, in Belgium, in Sweden, and in France. And so that's a short summary of the story of implantable pumps.
So it's interesting to me that today we've spoken to a number of your patients with the implantable pump, and they love this technology, think it's wonderful. We're a patient as well since 2007, and my experience, as the several other Americans who come to Montpellier to have this pump taken care of by you, and we're very grateful for that, we all express that life is so much easier. That on subcutaneous insulin, of course, it's life-saving. We're very, very happy to have it, but it's difficult to live with subcutaneous insulin. It's difficult to maintain the very proper blood glucose that our doctors tell us to do without getting very hypoglycemic and bouncing up and down. And this is a story that your patient said today, that before the implantable pump, it was a roller coaster. They go up and down and have problems and don't feel very well. And several of them mentioned something that I've mentioned to you, and you've validated, that when I got my first implantable pump, the very next morning I awoke and I felt different in a very positive way. And the patients also say this. So it seems very curious to me that going back many, many, many years, decades, those of you who are scientists and physicians in this area theoretically believed that this was a better way to treat diabetes. And then your patients who don't care about theoretical, it doesn't bother them, are telling you that in real practical life, it's exactly what you expected would happen. This is your experience?
Yes, well, as I told before, I think the main difference is the level of insulin in blood. So because to be well controlled, to have glucose in the target using sub-Q insulin, you have to over-delivery so that you can control hepatic glucose production. And so you are constantly in slight hyperinsulinemia. So, of course, insulin is going everywhere, including in the brain, and some people may be more sensitive to this. And so it probably contribute to the feeling, different feeling when you are on a sustained hyperinsulinemia and come back to a normal insulin level. And that's true that if you ask any diabetologist what is the ideal way of insulin delivery, they would say portal, because of course it's nature.
The liver.
So liver first, and there is in a way a conflict between the ideal way and the current practice. Of course, the current practice is very dependent about the availability of devices, because I'm sure that many of my colleagues in US are convinced that intraperitoneal insulin is the best way. The problem is that if there is no system available, of course, they cannot offer to the patients. Very few, like yourself or your friends, come to Europe to be treated by this way, but it could help many US citizens with diabetes who have this bad feeling that being in hyperinsulinemia, too frequent hypoglycemia to reach the target of A1C. And this is really a pity that they cannot benefit from this. And I would say even more now, because now we also have continuous glucose monitoring. And if you combine continuous glucose monitoring and implantable pump, and even with some algorithm between, so that the implantable pump will be driven by the CGM, you have what we call an artificial pancreas. And we have done some studies on this, and using peritoneal route is really very close to normal, because you can really have insulin when you need it, don't have it when you don't need it, and so you can really have very good control at nighttime, after the meals, even for exercise. So I would say intraperitoneal insulin is not an old idea and an old concept, but it shows the future, how we should use insulin the right way.
And isn't it so that you and your team have been some of the very early researchers looking at the artificial pancreas using the implantable pump, or also this percutaneous system where you go through the wall, which is not good for lots of people, but for its research purposes. So would you say that creating an artificial pancreas, as it's called, with intraperitoneal insulin is superior to the subcutaneous version of this type of device, which is very common?
Well, yes. Well, what is true, it is easier to reach good glucose control with intraperitoneal route, because the algorithm can work easily, because the problem of subcu is that you have delay. So you are constantly in the process of calculating how much insulin should be infused, so that in some minutes or hours, insulin level will be as you need. So it is quite complex. We started artificial pancreas here with intraperitoneal insulin, and it was easy, and glucose control was good. So when we have to expand to subcu route, because it is really, most of people in the world are treated with subcu route, well, it started to be difficult, because, of course, you have to work with mathematicians, with people who can make the algorithms, taking into account these delays. And so, in a way, it's much more complicated to have an artificial pancreas with subcu route than with intraperitoneal route.
And isn't there some truth to the idea that it's not only more complicated because of the dynamics of the insulin, how fast it starts, how slow, how long it stays around, but also the liver is really the workhorse organ that controls stable blood glucose.
Yes, it
so
was,
when it's not getting the insulin adequately, it can't do its job as well. Is this what's happening?
Well, the problem is that, it was shown by Claude Bernard last century in France. Yes, in France. He showed that liver was a key organ for glucose regulation, because it allows to stock some glucose when you have too much, and to release glucose when you need it. So this is a job that is controlled by insulin. So it means that the level of insulin you have close to the liver drives how much what is happening in the liver, stock insulin or release insulin. If you want glucose, sorry.
Yes.
And so, of course, if you want to do that with sub-Q insulin, you have to deliver a lot of insulin, so to have enough at the liver level. So that's why you have hyperinsulinemia, and so it causes a series of problems like hypoglycemia and weight gain. There was a study that was done in type 2 patients in the 1990s by Professor Sodek and in the Veterans Hospital in US, showing how implantable pumps were good for control of type 2 diabetes.
Even type 2?
Yes. And people were losing weight, which is quite unusual. When you deliver insulin to type 2 patients, most of them are gaining weight. Yeah. So it really shows that using the intraperitoneal route, the insulin is going where you need it. And you don't have too much insulin in the periphery and too few at the liver level.
So in the type 1 diabetic, like myself, for instance, who when I was a child, 8 years old, an autoimmune reaction occurred in my own body, killed the beta cells that make the insulin, so I had no insulin. Is it too simple an idea to say that the pancreas is really, the beta cell is really a signaling device? It watches the blood glucose go up and down, and if it goes up, it releases insulin to the liver, and if it goes down, it stops releasing insulin. So it's the sentinel, and then the signal goes to the liver in normal physiology, and the liver does all these wonderful things.
Yes.
So when I was a child and this happened, and I received subcutaneous injections, it was life-saving. I would have died if there had no insulin. But it was life-saving at a price, at a cost. And so by flooding the peripheral tissue with insulin, I could get enough to my liver so the liver could operate semi-positively, but the peripheral tissues were too much insulin, and it becomes, as your patients say, a roller coaster ride of high and low, struggling all the time. Something that happened in the United States when, in the early days of when a few of us had the implantable pump in the United States, a group got together with a psychologist, and the psychologist said, "I don't want to hear from the pump patients. I want to hear from your wives and your husbands and your boyfriend and girlfriends and significant others." And she said, "Tell me, what's it like living with someone who has this pump?" And all of them said, "It's a lot better than before they had the pump." And one of your patients today said the same thing. She says, "You know, when you don't feel good, and as you mentioned, you know, maybe you have hyperinsulation of the brain and the peripheral tissue, whatever, you're kind of cranky and uncomfortable." But then she said, "The day after I got the pump, I was better. It's nicer to be with my family, easier to do my work." And you hear this often, do you?
Yes, because, there is probably this role of insulin at the blood level, and there is also this risk of hypoglycemia, because when you are constantly fearing hypoglycemia, you cannot be relaxed, and you are always in the worry of having an hypoglycemia, and so it makes you more aggressive, less spontaneous, and so in your everyday life, you are not as if you had something that really replaced the function you need. So yes, it is.
For all the other things of life.
Yes. If you don't have this constant worry, of course, your life is easier. And we have instances of people who have had implantable pumps now from the early 1990s. Constantly, they change it when needed and so on. And these people would never stop it at no price. I mean, each time they may have a problem of battery failure or catheter blockage. It's less often now, but it happens sometimes. Well, they only ask for replacement as soon as possible because they feel different and they fear again hypoglycemia. Quite a large number of these people told that before they were treated with implantable pump, they had lost awareness of hypoglycemia.
We heard that from your
And this
patients
was
today.
also a constant worry,
Yeah.
being frightened to have an hypoglycemia.
Well, to never know if
Yeah.
you're going to pass out.
Yeah,
It
yeah.
happens without warning.
And so when you have a system that restores awareness of hypoglycemia, because you still may have hypoglycemia with implantable pump, but the difference, of course, is that you feel this hypoglycemia coming. A lot of people say even hypoglycemia are smoother, as they don't happen suddenly. And so you have time to take care of it, and so it's not so frightening as having a severe hypo. So yes, it's. I think this well-being is multifactorial. Probably insulin has a role, but also the loss of this constant worry of hypoglycemia is important. And also the comfort, because you have no external device. I mean, I agree that having an external pump is much better than having multiple injections, because you just use a needle every 3 or 4 days instead of several times per day. But when you have an implanted device, well, so it's you don't even need any needle to take care of insulin delivery. And with constant progress now on glucose sensor, we have one US patient who has the Freestyle Libre, which is a sensor that allows on-demand glucose monitoring. And he has an implantable pump. So it is really diabetes without needle, because he doesn't hurt his finger for glucose measurement, and he can deliver insulin without needle. So it's no more a dream, it's a reality. You can control your diabetes without hurting your skin anymore.
So there's only one choice of implantable pump right now. And it's the one that came from the 1980s, 1990s, some slight modifications. But it's quite large, and the battery lasts maybe 6-7 years, sometimes
up
longer.
to 10 sometimes.
Some people. If a catheter needs replacing, it requires to open the skin and do this. Would it be a major positive thing if a new pump was smaller and lasted 15 years in a battery and had a catheter that could be easily replaced in the doctor's office, just a small incision? Would this make a big difference to the population, you think?
Yes, because one of the limits of the dissemination, even in countries like France, Netherlands, where we have implantable pumps, is the size of the pump and quite an old technology. So that imagine that you are driving a car that was designed in the 1990s. It would look like a very old car. So this is a story we have with an implantable pump. Of course, it's better than what we may have on another way. But, I mean, the progress has so much increased since the 1990s that you could have the same pump brain in a very limited volume. You can also could have more concentrated insulin. There could be some technologies where catheter blockage could be cured by replacement without opening the pocket. So, I mean, there has been a stop in the development in the early 2000s. And so, yes, for sure, everybody agrees that it's time to modernize, and it would open the field to youngsters, because currently, until you have your final adult body size, it's too big. Yes, short women are asking also for more aesthetic device, and so yes, there is room for improvement. I would say that the metabolic problem is solved, but all what could make it even better needs to be done. It's time.
So in your patient population and also throughout France, you have over 2/3 of all the world population for implantable pumps. Would you take a guess of all these patients who have had these pumps, what percentage are dissatisfied with them, that don't like them?
It's very, very uncommon. Very few of them ask for explantation because they could not stand having this system. So
even with the large size and the catheter change and all these things that could go away with more modern technology, they still want this.
Yes, because it's changing so much their life that even if it's not 100% perfect, but at least it is better than whatever they knew about diabetes care. So
and if we advance this rather old technology to modern technology with all the improvements, they would only like it more.
Yes,
and adding a glucose sensor and algorithm to the pancreas.
Yes. Well, I would say that we are ready for an implantable artificial pancreas, because we even now, some research has shown that you can have an intraperitoneal glucose sensor that is working very well. So if you combine an implantable pump, implantable sensor, and some space where you can have an algorithm, I would say that most of the diabetic problem would be solved. So, I mean, the problems are solved scientifically speaking. So now, you can combine. Every tool is working well. So it's a matter of making it all in one with modern technology. Making people aware of this technology, because few people know about implantable pump. In France, of course, people know because, as you said, 2/3 of people are in France. But each time I speak of implantable pump in US, most people don't know. So it's really time to make diabetic people aware that this technology is ready to go, and that needs just initiatives to make it spread as it should. We have guessed how many type 1 patients would really benefit from implantable pump only because of hypoglycemia, and we are close to 20%.
Just for that reason?
Just for that reason, without saying about comfort, quality of life, and so on. Just because after some time, close to 15 to 20% of type 1 diabetes have hypo unawareness.
A very serious consequence.
Yes, of course, because it can happen when you drive, it can happen even during the night. So since we have continuous glucose monitoring, we became also aware that a lot of type 1 diabetic patients have hypo at night. They don't feel it then. And of course, it's not good for the brain, not good for the heart. So it's, I mean, there is a real population that would benefit from this implantable pump.
So in this population, this 15, say 20%, these are people who rather desperately need this pump. The other 80% would also benefit from it, from much better life, much better control, long-term consequences. So there's a very strong need for this technology.
Yes, for some people it's, I would say, vital. Like the current people who are using implantable pump, most of them, their life is really very poor if they don't have implantable pump. We have some women who had several pregnancies. Without this technology, they would never have any pregnancy. Some people who had hypo unawareness with sometimes several severe hypo per week. These kind of people, of course, for them it's a different life. Then you have other people who are better controlled. They were not so badly controlled so that they had no severe hypo at this frequency, but they were, to have good A1C, they had too frequent non-severe hypo. So most of them just put their A1C a little higher so that they would have less hypoglycemia, which is understandable. Yes. So these people who have an implantable pump are also better, and they are better on long term. We have shown that people, even some people who had some kidney problems with proteinuria, proteinuria disappeared with the treatment because the quality of control is very much improved. So, I mean, there is a lot even to learn more about this way of having a very good control on long term without hyper and hypoglycemia. And so, yes, there is really a need for this technology for a lot of type 1 diabetic patients.
So your research and your colleagues' research in this area has quite definitively shown that this is possibly the best way before we have a cure, which no one knows if we will have a cure or when. But until that time, this is the best way to treat type 1 diabetes.
The best way of insulin therapy, for sure. Yeah.
And so when you speak to your to professional meetings, say in the States, and your colleagues hear this, do they understand the work that you've done? Do they understand the research you've published showing that this is really the proper way to do this? And they are frustrated because they can't do this, the availability of pumps is so low?
Yes, well, from their medical school, they understand the concept and they are convinced, I would say, in advance. And of course, when you show the data and that it's better controlled, they say, okay, I was convinced, and you show me that I was true, because
it's give me a pump.
Yeah. And now, well, what is the break? That why don't you go forward?
Yeah.
We have no pump. Is the answer.
Yeah.
And so, of course, we would love to use this technology, but we have no pumps available. So I cannot send you all my patients in Europe. So we need some sparkle that makes this live again and become available in
Create
US.
a new modern pump. And
yes. Yeah.
Well, Professor Renard, as you know, I'm very grateful to you. I'm happy in '95 that we met, and when the U.S. lost the pump in 2007, and I asked you if you would take care of us, you said yes, and we're very grateful for that. I wish you would move to the United States and bring your team with you, so I won't have to fly back to Montpellier so often. But thank you again very much. We are much appreciative, and please keep doing this good work. I think we will be successful.
Your smile is the best reward of the energy we spent.
Thank you very much. Thanks.
Bye.